Okay, my name is Deepthi. I'm a final year student from Kilpauk Medical College. My case today is an acute cerebrovascular accident. A 38-year-old male, Mr. Prabhakaran, residing in MGR Nagar, who is a right-handed individual and carpenter by occupation, has come with chief complaints of difficulty in using the right upper limb and lower limb for 5 days, deviation of angle of mouth to left for 5 days, and slurring of speech for 5 days.
Okay. So Dr. Deepthi is a very young male. Okay. First of all, the thing that you need to note is because he's a less than 40-year-old person. And
Yes, sir.
importantly, whenever you discuss such a young person coming with probably, I think at the end of the discussion, you will be having diagnosis of cerebrovascular accident, right? CVA is going to be a diagnosis. And so in that situation, it's better that you always be ready about causes of young stroke in exams. Okay, they'll be asking you.
Yes, sir.
Be prepared for that. So that's one point I want to tell. Whenever you discuss anyone less than 40 years and having a neurological issue, young stroke diagnosis is very important. Plus, at the same time, there is no standard consensus. One important problem about discussing the case in exam is the fact that two problems students face. One, it's not an MCQ exam. Okay, there are not going to be any options. They're not going to be A, B, C, D. So entrance exams are far better. And second is it's completely subjective. Completely subjective in the sense what examiner says, whether it is right or wrong, you need to accept it at the end of the day. And arguments are not going to help. These are some basic take-home points. Before starting any case discussion, always be humble. Don't argue with the examiners. Whatever they say, accept it. And there might be varied opinions because what is 4 power for you might be 3 for me. What is 2 reflex might be 3 for me. So it is variable. It is completely subjective. So there are some differences, but let us try to come to a conclusion amongst these differences. So I'm not trying to, why I told this is, I am not trying to find fault in your presentation. That is number one I want to say. I'll just refine probably in my own way. So because again, it is subjective, a different examiner might be expecting a different situation, but I'm telling from my perspective. So from the first slide, what you presented, I would suggest that don't use the word male or a female. Okay. So always in the exam, the language should be a little better. Use the word a lady or a gentleman always. So that will be far superior. So in your way of presentation, the first approach that you're giving to the examiner or giving to someone, when your language is good, use the word gentleman. It sounds so soothing and pleasing. So that's the very basic thing. So that's what I would expect if a candidate of mine is going to present a case to me. Okay, very simple. But here is a right-handed individual. Okay. So is there any need to say that the patient is a right-handed individual at this point itself? You don't know, isn't it? So whether the patient is a neurological case or a hematological case or endocrine case or a respiratory case or a gastro case, is there any need to really say the handedness in the first place? Actually, no need. Okay. They'll be asking you what is the need. So most of the times in when you go to a clinical exam, you're not telling certain things is more important than telling a lot of things. So don't tell certain things. So this handedness need not be told here. Maybe during the general examination part or maybe higher mental function examination, that time you can tell the handedness. Right now, I don't think it's really needed. And maybe occupation is fine, age is fine, all these areas, that's fine. And again, nobody is going to ask the address. So why the address is very important, because is there any area that is endemic to a particular disease? For example, when we are discussing about COVID, so we actually tell whether it's high endemic zone or low endemic zone. What is the amount of prevalence of a case in that particular area? So that only we are asking about the area. Okay, area per se is not that important. Maybe low socioeconomic status or high economic status, all those things. But anyway, no need to pinpoint and tell what is the area. Maybe that's fine if your examiner wants all those things. Okay, so you told like difficulty in using right upper limb and lower limb. Okay, this is a chief presenting complaint for the last 5 days, and deviation of angle of mouth to the last 5 days, yes, and slurring of speech for the last 5 days. So when you tell it's a chief presenting complaint. So what is the idea of a chief presenting complaint?
The chief presenting complaint is what the patient comes to us with. What the patient says goes. Preferably, there will be no medical terms. It will be like how a patient would tell us, but in
Okay,
English.
good, very good. But one small correction I would say is the chief presenting complaints are the ones that bothers the patient the most. Okay, that is the chief presenting complaint. Okay, it's not just whatever the patient tells, you can take it as a chief presenting complaint. For that matters, they will tell hundreds of things. I'm feeling tiredness. I'm feeling, like little bit of numbness in my hand. So many neck pain they will say. So many things they will say. You cannot write everything in the chief presenting complaint. Chief presenting complaint means what is the problem that bothers them the most. Okay, so which makes them disabled, which make them come to the hospital and get admitted. So that's the chief presenting complaint. Fine, all these are fine. Whatever you told is fine. So, but just I'm telling, maybe sometimes some students will tell like chief presenting complaints itself, like a list they will say like 8 problems, 9 problems, 10 problems. So that is not warranted. Okay. So even if you want to reduce your burden, you can just say like this difficulty in using the right upper limb, that's enough in the exam. I mean, to be honest, because that will be the most important complaint of the patient. Okay, deviation of angle of mouth and slurring of the speech. If you really note in the what the patient says, in a patient who's having a, because I studied your case, but anyway, so if you see, like the patient is having a total weakness, in that situation, nobody is going to be very much bothered about the slurring of speech or the deviation of angle of mouth, which means they are associated complaints. Okay, they are not the chief presenting complaint. Chief presenting complaints is patient is not able to walk. Patient is not able to do things with that particular limb that is paralyzed. So that's going to be the chief presenting complaint. Okay. The other two things, it might be if the patient really tells, you can say, but the problem with this is if you go on telling more and more chief presenting complaints, you need to elaborate more and more in your exams. Okay, they will ask about everything in detail. So that will become a little bit of burden in the beginning itself. So try to reduce the burden and calm down the examiner by telling only one chief presenting complaint most of the time, and try to explain only that during the exam. That's a small trick. So just like that. Okay, fine. So otherwise it's fine. It's very fine, no problem. Then moving on to the next thing.
History of presenting illness. The patient was apparently normal 5 days back. On the day of the neurological deficit, he woke up normally, went about his daily activities, and around 9 p.m. after dinner, he felt giddy and noticed difficulty in using the right upper limb and lower limb, and a deviation of angle of mouth to the left side, along with slurring of speech. The next day morning, he was taken to a private hospital, from where he was referred to the OPD.
Okay.
To the hospital.
A very good presentation. Okay, patient was apparently normal 5 days back. On the day of neurological deficit. Okay. So, or you can simply write on the day of event also. So, on the day of event, neurological event. So, because deficit or not is not a patient word.
Yes, sir.
So that's why you can use the word event. That's far better. I mean, again, remember, it is all subjective. I'm not trying to bully or I'm not trying to discriminate any student. Okay, so fine. All right. So day on usually he woke up normally, went about his daily activities around 9 p.m. and having dinner, he felt giddy. So which means it's happened very suddenly. That's what your history of presenting illness is. Because the idea of elaborating the presenting illness is to say what is the onset, whether it is insidious or acute or subacute or chronic. So that is what you're trying to say. So what you're trying to say is overall the end result is it happened all of a sudden. Okay, at around 9 p.m. immediately. So you are trying to say it's an acute onset, right?
Yes, sir.
Okay, so fine. So very good. So it's an acute onset because there are some diseases which come acutely. There are some diseases which present chronically. There are some diseases which come subacutely. And one of the important things that come acutely is cerebrovascular accident. Okay, because there are other diseases like demyelinating illness which might have a long course. There are other diseases like tumors which might have a long course. Okay, so but here you are thinking about some cerebrovascular accident which happens usually very, very acutely. So that's what your take-home message from this is. And usually again, this deviation of angle of mouth and slurring of speech, I don't think the patient would have told. Really, that is something you have added. I can easily guess that because when I see a lot of patients, they come with weakness. That's the most important thing. So if you explain that, that is more than enough. Deviation of angle of mouth and slurring of speech is something that is not going to be very significant unless until the patient's only complaint is slurring of speech and deviation. For example, take a Bell's palsy. Okay, what will happen in Bell's palsy? The primary problem of the patient is my mouth is deviated. So in that situation, the primary problem will be my speech is not proper because of dysarthria. That's how it's going to be. But here the primary problem of the patient is the weakness. That is enough. Okay, so this is unnecessary trap. They'll be asking more and more questions. And this is only I've added the associated symptoms also. Okay, the next day morning. Okay, 9 p.m. he had a problem. But why the patient went only the next day? Did you ask anything specifically?
Sir, might be because the weakness was maybe he thought he was tired and also the difficulty of going to the hospital at night.
No, there is something there that's wrong that happened with the patient, or that too especially young patient. So try to ask some more time. I mean, at the end of the presentation, you should read your own presentation. That's very important, ma'am. Okay. Always, it should make sense to ourselves. So if something doesn't make sense, try to go back and ask again. Okay, that will automatically come when you start presenting more and more cases. Then you start inquiring more and more cases. And one problem that an undergraduate faces is many times, like you ask something, the patient will tell something, and when the examiner comes, the patient tells something else. This commonly happens at undergrad level. The reason for that is very simple, because when they see you guys, they know that you're junior doctors, and they will not answer in a very responsible way. They will not say everything. And you might be like 10th person or 15th person to ask these questions, because many other people would have examined already. So that is the reason why patients might be very reluctant to answer you. But patients, like when the big doctor comes for them, like they are big doctors, isn't it? So when senior doctors or big doctors come, like they will be very responsible and they will answer something different also. That can happen. That's completely normal. I understand that. So no need to worry about that. But this is something that is completely irrelevant according to me, because he waited for one whole night. Okay. Then the next day morning only he came to a private hospital. Because when I go back to your presentation, because you mentioned power as 0/5. I've read through the presentation just 10 minutes ago. So it was 0/5. So a 0/5 power and unilateral problem. Okay, only one side the patient is having problem, and he's not able to use that to which hand? Right hand, which is his dominant hand. Okay, it's not dominant. He's right-handed or left-handed?
Right hand.
Right-handed. Dominant hand, not able to use. Okay. So like, I don't think that's proper. That's right. Okay. So there is something that's going on here that you need to go back and inquire. Okay, fine. Anyway, so let us assume the next day morning he was taken to the private hospital, and from there he was referred. So what is the importance of something called LSW? We call it as last seen well time when it comes to a neurological case. What is the importance of last seen well time when it comes to neurological?
Sir, it depends. The treatment depends upon when the patient was brought to the hospital. If it is less than 6 hours or more than 6 hours.
Okay, nice. All right. Completely understandable. So less than, what is the cutoff?
6 hours or 3 hours, sir. I am not really sure.
No, not 6 hours. It's 4.5 hours. Okay, 4.5 hours is very important. So the window period for doing a thrombolysis is 4.5 hours. And what is the window period for doing mechanical thrombectomy? There is something called mechanical thrombectomy, where you can directly access the clot inside the vessel and you can extract the clot through a catheter. What is the window period for a mechanical thrombectomy? It is 6 to 24 hours. Okay, depending on a lot of issues. I mean, nobody's going to ask you an exam. Ideally within 6 hours, but it can be up to 24 hours also. You can do mechanical thrombectomy. That's the latest ACHA guideline. So that is the importance of asking for last seen well time. Less than 4.5 hours for thrombolysis, and 6 to 24 hours, within 6 to 24 hours for mechanical thrombectomy. That is why we asked that last seen well time. Okay, according to you, this patient came next day morning. Okay, next day morning only. Previous day 9 o'clock he had a event. But do you think this patient is eligible for thrombolysis?
No, sir.
Yes, this patient is not eligible for thrombolysis because he has crossed the window period. But is he still, I mean, by the time he came to the hospital, was he still eligible to mechanical thrombectomy just based on the window period?
Yes, because it's not been 24 hours.
Yeah, 6 to 24 hours, but you need to do a lot of imaging. Okay, we don't want to discuss about that because it's a clinical case discussion. But still, in certain patients, still this patient, if everything is proved, this patient might be eligible for mechanical thrombectomy by the time he came. But still, it's a very late presentation. Okay, but something has happened in between, and you need to figure it out. What made the patient come very late to the hospital? So what I suspect is, okay, I mean, Dr. Quads always, like makes funny comments like this. I must be experimenting with Dr. Papa on their medications. Okay, cool. It's a nice one, man. Thank you. Okay, all right. So what I'm trying to say is, my guess will be, suppose if this is really true, my guess would be patient would have had a TIA. Okay, patient would have had a TIA. My guess, purely my guess, subjective guess. If this is the real history, then patient would have had a TIA, transient ischemic attack, which resolved within 5-10 minutes, and have gone to sleep. and in the night you would have got a stroke. Morning when you woke up, you would have noted that there is a weakness. So why we worry about TIA? What is TIA? Tell the
Transient ischemic attack.
What is the definition?
In TIA, the patient has weakness of the limbs, but which resolves by itself.
Okay,
Unlike a stroke.
weakness of the limbs which resolves by itself. Is there any specific definition?
It resolves by itself in less than 24 hours.
Within 24 hours, okay. Any focal neurological deficit that resolves within 24 hours is what we refer to as a transient ischemic attack. What is the definition of an ischemic stroke?
An ischemic stroke does not resolve by itself, unlike a TIA.
Okay.
And
any focal neurological deficit that is persisting beyond 24 hours, and if it is due to a vascular cause. Okay, because tumors also can cause what? Focal neurological deficit. But that's not a stroke. Okay, to call it as a stroke, it should be a vascular event that is persisting, that is having a persisting focal neurological deficit beyond 24 hours. Okay, this is the WHO definition for stroke. They might be asking you. Okay, so my suggestion will be this patient would have had a TIA probably to start with, and he would have a weakness. It would have resolved within 10 minutes or 15 minutes, and after that he would have went for sleep, probably thinking that it's fine, tomorrow morning we'll go and check. By the night, we'll have a stroke. You would have had a subsequent stroke. And why we were worrying about TIA? So why you need to worry about TIA?
Why we need to worry about?
TIA. It resolves by itself, no? Why you need to worry then?
Recurrence has really bad prognosis, sir.
No, okay, fine. So you are correct, but you can tell it in a more refined way. So how you can tell is the patient who's having a TIA has a increased risk of subsequent full-blown stroke.
Okay.
That's why we are worrying about. So a patient comes with TIA the next day. So when is the risk of stroke maximum after a TIA? Within the next 48 to 72 hours.
Okay,
so
sir.
That is why we are trying to analyze this TIA. We're trying to understand this TIA faster and try to treat them faster, because it has a high risk of stroke in the next 24 to 48 to 72 hours. That is why I was asking again and again. So patient who didn't come to the hospital in the night with such a bad deficit means he would have had a TIA probably. Then next day morning, he would have woken up with a stroke that made him come to the hospital. That is what my guess will be in your presentation. Okay, go ahead.
The patient has a history of inability of lifting right upper limb above his head, history of inability in combing or buttoning shirt, inability in mixing food, writing, holding objects, difficulty to stand up from sitting posture, history of buckling of knees, history of difficulty in holding slippers, no history of difficulty in lifting head off the pillow, and I can't read the last one because there's a pop-up window saying extend class.
Okay, fine. So there is no history of difficulty in turning from side to side. So what you can do, if there is a pop-up window like that, you just try to refresh once. So there is, you have this thing, no? The URL.
Yeah.
You just click on that and try to click enter, refresh again.
Okay, sir. Yeah.
Now it's fine? Okay.
Yes, thank you.
All right. So now why you're telling all these things? Now, which means you're trying to explain this presenting illness, right?
Yes, sir.
Yeah, trying to explain this presenting illness, that is difficulty in using right upper limb and lower limb. Okay. So what is this? Why you are using this?
We're trying to figure out if the weakness is in his distal muscles or his proximal muscles.
Okay, distal muscles or proximal muscles. Okay, cool. So what difficulty you're facing here? The patient lifting above the head.
Proximal muscles, sir.
Did the patient really say, I mean, apart from our routine discussion, did the patient really tell that I'm not able to lift above my head?
No, sir. We ask leading questions, to find out if he has
the
distal or proximal.
Okay, he's having history of difficulty. So your power is 0/5.
Yes, sir.
Right, in the examination part.
Yes, sir.
0 means absolutely it's a plegia. It's not hemiparesis. So, okay, fine. So, okay, cool. So lifting above its head means it's proximal. Okay. Combing or buttoning shirt. Why?
Distal finger muscles of the fingers.
The small muscles of the hand. That's what you're talking about. Okay. Then
Yeah.
mixing, writing, holding objects.
Same distal muscles of the
The
finger.
small muscles of the hand. Okay. Then stand up from sitting posture.
Stand up from sitting posture. Proximal muscles of the leg.
Okay, you're trying to analyze again proximal muscles of the leg. Okay, buckling of knees.
Muscles of the leg, sir.
Proximal or distal?
Proximal.
Okay, cool. That's proximal because you're trying to analyze quadriceps.
Yeah.
Okay.
The knee.
Holding slippers.
Distal muscles. Oh, the distal muscles of the leg.
Okay. But that is the beauty of clinical presentation. Usually, like it is subjective, but a patient who is completely bedridden, why you want to hold slippers? Okay, cool. So fine. Jokes apart, that's fine. Yes, that's why I'm asking. That's why Dr. Quartz is asking if there is a complete plegia, is there any relevance in asking such details? Actually, no. That's what I asked. What is the power? Okay, you told it's 0/5. So that's why there is not much relevance in asking. It's a complete weakness. Okay, but still, what is the human pattern of weakness? Because the idea of telling this is, tell me one condition that causes typically proximal weakness. Just one condition that causes predominantly proximal weakness.
Proximal weakness. It can be a lot of reasons. Generally, myopathies.
Yes. Yeah. Some students will be helping you. That's fine. One student, Money Heist, is telling PMR. What do you mean by PMR? Polymyalgia rheumatica. Polymyalgia rheumatica never ever causes weakness. Okay, it causes only pain and stiffness. It's a rheumatological condition, Dr. Money Heist. So please don't tell these kind of answers to your examiners. Okay, so PMR will never cause weakness. It only causes pain and stiffness. Cool, all right. So if they ask you one condition that causes proximal weakness, muscle disorders or neuromuscular junction disorders. Okay, that's very important.
Okay.
So that's going to cause proximal weakness. That is why you're asking this history, which means only proximal, no distal. Go about muscle cause. And what about your distal weakness, predominantly distal weakness? What do you think about?
Predominantly distal weakness is, I'm not sure, sir.
You're not sure. Any condition?
Maybe a neuron
LMN weakness.
problem.
Okay, typically lower motor neuron type of lesions, you will have more of a distal weakness. But what is the term that you have to use for LMN palsy? If you're talking about an LMN palsy, what is the term that you have to use? Segmental weakness. Okay, that is very important.
Okay.
In LMN paralysis, it will be more distal and more segmental and patchy weakness. That's very important. Why it's segmental? Because take, for example, a median nerve. For at your level, at a final level, let me tell you median nerve involvement. Does median nerve involve all the muscles?
No, it doesn't.
No, it doesn't. It involves only selected group of muscles. What is the hand muscles that are involved in median nerves? These are called as loaf muscles, right? Your LOAF.
Yes,
okay, the lateral lumbricals, opponents, then abductor of the
abductor pollicis longus and
pollicis brevis. Okay, then
brevis and flexor muscles.
Okay, the thenar muscles. Okay, so these are the muscles that are supplied by the median nerve. So which means you are going to have thenar vesting and selective involvement of certain muscles. That's why LMN means patchy, segmental, more distal. That's why we are asking this. And what will be the UMN pattern of weakness? Mainly call it an UMN weakness.
UMN weakness is when wasting is not present.
What is the UMN pattern of weakness? I'm not asking how to differentiate between UMN and LMN. What is the UMN pattern? I told you, muscle will be proximal, LMN will be segmental and more distal. But what about UMN? Okay. I'm not talking about the definition, Dr. Sujit. I'm asking about UMN means what is the pattern? So remember, UMN typically affects your abductors of the upper limb and your small muscles of the hand, the distal muscles. Okay, abductors, and it will be affecting the extensors of the upper limb. Abductors, extensors, abductors, extensors, and the
small muscles of the hand.
The finger muscle, the distal muscle. These are the typical UMN pattern of weakness. Imagine you try to do the thing what you see in the TV, in the television. When some patient in movies or in serials, you would have seen a patient who's suffering from hemiparesis. So how they keep the hand? in your left hand position right now.
Oh,
Okay.
okay, sir.
That's how they keep the hands, right? So like
Oh.
this. What does that mean? Which means your abductors are weak, so your hand is adducting. Okay. Then your extensors are weak because of overaction of flexors. Your hands are getting what?
Flexed.
Flexed. Okay. So this is what is going to happen. So typical human distribution of weakness is abduction weakness and extension weakness. That is why you do. And what is the pattern in the lower limb? So I told you abductors and extensors of the upper limb are going to be more involved. What is the pattern in the lower limb?
Distal muscles of the
Leave that.
limb.
Opposite. What is
Proximal muscles of the
opposite
limb.
flexion?
So
Opposite extensors. It's flexors.
So flexors will be.
So flexors will be more involved in the lower limb. So which means when you see a typical human pattern of weakness, the hands will be flexed, the upper limb will be flexed or extended.
Upper limb it will be flexed.
Flexed. What will be the lower limb? Extended or flexed?
Extended.
Cool. That's how you see a patient typically. So patient typically you see in the wards who's coming with a late hemiparesis, who's not, treated with proper physiotherapy, will have what? Arm close to the body, abducted.
And legs away from the body.
Abducted and flexed, and your legs will be extended.
Extended.
Clear? That is
yes,
why
sir.
If they ask you, how will you do plantar response? In extended limb or flexed limb?
Extended limb.
Yes. Why you do an extended limb? Because it's a sign of
paralysis.
UMN palsy. Plantar will be positive in UMN palsy only. That is why it should be done in extended position. Okay, leg will be in extended position. Okay, and at the same time, patients will be having what kind of gait? You can explain so many things. Patient will have what kind of gait? In typical human hemiparesis, what is the gait you expect?
Abnormal gait, sir. If they have weakness.
Abnormal gait. What is the gait you will expect in a patient with human weakness? Circumduction gait.
Okay.
So what is circumduction gait? The patient will rotate the limbs. Why the patient is rotating the limbs? So for example, let us assume this is the leg. Okay, this is the leg. So when you want to walk, how will you walk? You flex. Okay, flex the leg and then extend and then flex and then extend. Okay, why you flex? Because you want to move forward. Flex and then keep the legs in front. Suppose in case if you have a flexion problem, which means your legs are only extended, so you cannot flex at all. So what the patient tries to do, he tries to rotate the leg away from the body and then tries to come to a point. Rotate the leg away from the body and tries to come to a point because the patient cannot flex. That is the reason why the patients get that kind of a circumduction
gait.
That is because patients are not able to flex their limbs. Okay, clear. Typical circumduction gait. That is the reason why you are asking all this history. That's why we are seeing. So because neurology is more of an examination. Neurology is more of clinical approach. Investigations come later on. Okay, but clinically, what you need to understand? What are the pathways? Everything can be assessed. That's why we do that. Okay. I told you about human pattern of weakness. I told you your LMN pattern of weakness. I told you your neuromuscular junction, muscular pattern of weakness. Clear?
Yes, sir.
Yes. So these are the 4 important patterns of weakness that you need to know. At the same time, evolution of weakness is very important. Okay. Did you tell about evolution of weakness? Whether it happened all of a sudden? Yes, you have told already. Which means suddenly he noticed difficulty in using both upper limb and lower limb. Which means both upper limb and lower limb have involved simultaneously. Which means he didn't have that first upper limb, next lower limb, or first lower limb, then upper limb. He didn't have those kind of weakness. There is no evolution. Suddenly it happened, and both upper limb and lower limb happened all of a sudden. Again, that tells you it's a cerebrovascular accident. Because if you have ascending pattern of weakness, what will you suspect?
Guillain-Barré syndrome, sir.
Okay, yes. Ascending weakness can happen in many conditions, but at your level, at your final year level, one of the most important diseases that cause ascending pattern of weakness is Guillain-Barré syndrome. What produces descending pattern of weakness? So because when you talk about ascending, they'll be asking about descending. Descending weakness.
Sir, I'm not sure.
You're not sure. Okay, cool, no problem. Nothing to it. This is a casual discussion. See, there is absolutely no harm in telling I don't know. Okay, that's very important. And even like when I go to exam at this point, even I will say that I don't. Okay, we cannot know everything. So it's all about improving day by day. So whether I don't know something today, whether I know tomorrow or not is the question. That is what is more important, and not like whether I don't know at that point of time. So when you are born, we are all born idiots only. So I born with zero knowledge. Everyone is born with zero knowledge. So it improves over a period of time. So don't hesitate in telling I don't know. Never. It's never ever a sign of weakness, because at every point of time, our entire community is feeling that when you say don't know, it's a sign of weakness. It's a sign of mental weakness, or you are inferior. No, it's not like that at all. When you tell you don't know, you have the courage to tell I don't know, which means you are strong. Okay, strong enough to say that you don't know. That is very important to understand. So never hesitate anytime. Okay, cool. So what about your descending weakness? Central spinal cord syndromes. Okay, that is what I'm expecting. So when you talk about a descending paralysis, think about a central spinal cord weakness. And second condition is botulism, botulinum toxin poisoning. Okay, two conditions will produce us descending weakness. Diphtheria can produce both ascending as well as descending, because one student is answering that. We can produce both ascending and descending, but one important descending weakness is going to be your botulism, and second it's going to be your central cord syndromes. What are the examples? If you utter the word central cord syndrome, next exam will be asking what are the central cord syndromes. Tell me one example of central cord syndrome.
Brown-Séquard syndrome.
No. Brown-Séquard is not a central, it's an hemisection of the spinal cord. Okay, central cord syndrome is going to be syringomyelia. Okay, conus medullaris is not a central cord syndrome. It's something different. It's not coming in classic spinal cord syndromes. It's a separate spinal cord syndrome. Okay, central cord syndrome, one is syringomyelia. Second, intramedullary spinal cord tumor. Okay, intramedullary. What do you mean by intramedullary? If there is a tumor within the spinal cord, within the substance of the spinal cord. If there is a tumor outside the spinal cord compressing on the spinal cord, that is extramedullary. If there is a tumor that is within the spinal cord, inside, that's going to be intramedullary tumor. So intramedullary tumors of the spinal cord and syringomyelia, both are classic central cord syndromes. And any central cord syndrome is going to produce descending paralysis. Apart from that, you can tell botulism also. Descending paralysis. Ascending, always answer GBS at a final year level. Descending, always answer botulism and central cord syndrome. Cool. So that is why that evolution of weakness is very important. Either it happened all of a sudden, or it happened in a kind of a pattern. And some diseases, like will involve lower limbs first, then right lower limb, left lower limb, then right upper limb. There are a lot of diseases in this kind of pattern, but it's beyond the scope of the undergraduate discussion. So I'm not telling all this, but two important, descending, ascending, both you should know at least before appearing to the exams. So, okay, according to you, it happened all of a sudden. And why you asked about that history of lifting head off the pillow?
Neck stiffness.
No, not neck stiffness. You're talking about neck weakness.
No.
Okay. What condition will produce neck weakness? So you asked about neck weakness, isn't it?
Yes, sir.
What condition will classically produce neck weakness?
Meningitis is neck stiffness, right, sir?
You're talking about neck weakness, because difficulty in lifting head off the pillow means you're talking about neck weakness, not stiffness. Okay. Two conditions. Very classic. GBS, hypokalemia. Okay. This is what the examiners will expect. In demyelinating peripheral neuropathies like GBS, or in patients who are having hypokalemia, or some patients with muscular dystrophies. Okay. Severe muscular dystrophies. Again, there are a lot of patterns in muscular dystrophies we don't want to discuss in detail, but these are the conditions that's going to produce neck weakness. That's why you're asking this history. Okay. Why you're asking this history of difficulty from turning side to side?
Neck muscles, sir. Neck muscle weakness.
You're not talking about neck muscles, you're talking about trunk weakness. Okay. You're talking about trunk weakness. How else you can assess the trunk